Acute stress disorder represents a significant psychological response that can emerge in the immediate aftermath of trauma exposure. Defined as a constellation of symptoms occurring within the first month following a traumatic event, this condition serves as both an important clinical entity in its own right and a potential precursor to post-traumatic stress disorder, PTSD. Understanding acute stress disorder provides crucial insights into the human response to overwhelming experiences and offers opportunities for early intervention that may prevent longer-term psychological difficulties. The diagnostic criteria for acute stress disorder require exposure to actual or threatened death, serious injury, or sexual violation, whether experienced directly, witnessed in person, or, in some cases, learned about when occurring to close family members or friends. First responders repeatedly exposed to traumatic details, such as paramedics collecting human remains or police officers repeatedly exposed to details of child abuse, may also develop the condition. Following this exposure, individuals must experience 9 or more symptoms from 5 categories: intrusion, negative mood, dissociation, avoidance, and arousal that cause significant distress or functional impairment. The temporal boundary distinguishing acute stress disorder from PTSD is important. Symptoms must develop within 1 month of the traumatic event and persist for at least 3 days, but less than 1 month. When symptoms extend beyond the 1-month mark, clinicians reassess for possible PTSD diagnosis. Intrusion symptoms represent a core feature of acute stress disorder, manifesting as unwanted memories of the traumatic event that intrude into consciousness against one's will. These intrusions may take several forms, including distressing memories that arise spontaneously, recurrent dreams or nightmares related to the event, or, most intensely, flashbacks, dissociative reactions where individuals feel or act as if the traumatic event were recurring in the present moment. During these episodes, sensory impressions from the trauma can feel vivid and immediate, temporarily disconnecting the person from awareness of their current surroundings. Physical reactions to reminders of the trauma, such as a racing heart, shallow breathing, or nausea when encountering trauma-related cues, also fall within this symptom cluster. These intrusions often feel uncontrollable and unpredictable, contributing significantly to the distress experienced by those with acute stress disorder. Dissociative symptoms feature prominently in acute stress disorder, distinguishing it somewhat from other trauma-related conditions. In the aftermath of overwhelming experiences, some individuals experience an altered sense of reality, feeling as if they are in a fog or dreamlike state, a phenomenon known as derealization. Others experience depersonalization, a disturbing sense of detachment from oneself, perhaps feeling as if they are floating above their body or as if they themselves are not real. Some describe feeling emotionally numb or experiencing the world as distant or colorless. Dissociative amnesia may also occur, where individuals cannot recall important aspects of the traumatic event, particularly central details that would normally be encoded into memory. These dissociative responses likely represent psychological protective mechanisms that buffer against overwhelming emotional experiences, but they can interfere with processing and integrating the traumatic event in adaptive ways. Negative mood represents another dimension of acute trauma response, characterized by a persistent inability to experience positive emotions such as happiness, satisfaction, or loving feelings. This emotional constriction goes beyond normal sadness, representing instead a profound dampening of the capacity for positive affect. Individuals may report feeling emotionally flat or dead inside, unable to connect with pleasurable experiences or feel joy even during previously enjoyable activities. This anhedonia contributes to a sense of disconnection from others and can strain relationships during a time when social support is particularly crucial. The negative mood component of acute stress disorder highlights how trauma can temporarily disrupt fundamental emotional processes, affecting not just fear responses, but the entire emotional landscape. Avoidance behaviors typically emerge quickly following trauma exposure, as individuals attempt to manage their distress by steering clear of potential reminders. This avoidance operates on 2 primary levels. External avoidance involves efforts to avoid people, places, conversations, activities, objects, or situations that might evoke distressing memories or feelings associated with the traumatic event. For instance, someone who experienced a serious car accident might avoid driving, refuse to travel on the road where the accident occurred, or decline to discuss the event with others. Internal avoidance involves efforts to escape distressing memories, thoughts, or feelings associated with the event, perhaps through deliberate thought suppression, distraction, or in some cases, substance use. While these avoidance strategies may provide temporary relief, they ultimately interfere with processing the traumatic experience and can lead to significant constriction in life activities. Arousal symptoms in acute stress disorder reflect heightened reactivity of the autonomic nervous system, which remains on high alert following trauma exposure. Sleep disturbances are common, including difficulty falling asleep, staying asleep, or experiencing restless, unrefreshing sleep, often exacerbated by trauma-related nightmares. Irritable behavior and angry outbursts may occur with little or no provocation, sometimes expressed as verbal or physical aggression toward people or objects. Hypervigilance keeps individuals scanning their environment for potential dangers, making it difficult to relax or feel safe even in secure settings. Problems with concentration interfere with daily tasks as attention repeatedly shifts toward potential threats or trauma-related thoughts. Exaggerated startle responses manifest as jumpiness in reaction to unexpected stimuli, such as loud noises or sudden movements. Together, these arousal symptoms create a state of exhausting physiological activation that significantly impacts quality of life. The neurobiological underpinnings of acute stress disorder involve several interconnected systems. The body's stress response system, the hypothalamic pituitary adrenal (HPA) axis, typically activates during danger, releasing stress hormones including cortisol and adrenaline that prepare the body for fight or flight responses. In the aftermath of trauma, this system can become dysregulated, with some individuals showing elevated stress hormone levels while others paradoxically show blunting of the normal stress response. Neuroimaging studies have identified alterations in key brain regions following recent trauma, particularly hyperactivity in the amygdala, the brain's threat detection center, and reduced activity in prefrontal cortical regions responsible for regulating emotional responses. The relationship between these acute neurobiological changes and long-term adaptation remains an active area of research, with growing evidence suggesting that certain patterns of biological response in the immediate aftermath of trauma may predict who will develop chronic PTSD. Risk factors for developing acute stress disorder exist at multiple levels. Pre-trauma factors include female gender, prior psychological disorders, particularly anxiety or mood disorders, previous trauma exposure, and certain personality traits, such as neuroticism. Trauma-related factors also influence risk, with interpersonal trauma such as assault or abuse typically carrying higher risk than non-interpersonal traumas like accidents or natural disasters. The severity, duration, and proximity of the traumatic exposure play significant roles as well. Post-trauma factors, particularly the availability of social support and the presence of ongoing life stressors, strongly influence adaptation. Cognitive factors such as catastrophic appraisals of the trauma and its consequences also contribute to risk. Individuals who interpret their acute symptoms as signs of permanent damage or who catastrophize about future negative outcomes appear particularly vulnerable to developing acute stress disorder and subsequent PTSD. The relationship between acute stress disorder and PTSD represents a complex area of clinical and research interest. While initially conceptualized primarily as a predictor of PTSD, with early research suggesting that most individuals with acute stress disorder would progress to PTSD without intervention, subsequent studies have revealed a more nuanced relationship. Approximately half of those who develop PTSD do not initially meet criteria for acute stress disorder, suggesting somewhat different pathways or risk factors may be involved in acute versus chronic trauma responses. Nonetheless, the presence of acute stress disorder does significantly increase risk for subsequent PTSD, with meta-analyses suggesting that about 50 to 60% of those with acute stress disorder will go on to develop PTSD without intervention. This predictive relationship, while imperfect, provides an important opportunity for secondary prevention through early identification and treatment of high-risk individuals. Assessment of acute stress disorder requires sensitivity to both clinical and contextual factors. Clinicians must distinguish between normal, adaptive responses to trauma and the more severe, impairing reactions that characterize acute stress disorder. Standardized assessment tools such as the Acute Stress Disorder Scale or the Stanford Acute Stress Reaction Questionnaire can aid in systematic evaluation of symptoms. However, timing is crucial. Assessment conducted too early following trauma may capture transient distress that would resolve naturally, while delayed assessment might miss the window for early intervention. Cultural factors significantly influence both the expression and interpretation of post-trauma symptoms, with some cultural contexts emphasizing somatic complaints while others focus on psychological manifestations. Effective assessment incorporates cultural sensitivity, recognizing that the meaning assigned to symptoms and the language used to describe distress vary considerably across cultural contexts. Early intervention for acute stress disorder aims to relieve suffering and prevent progression to chronic PTSD. Psychological first aid represents a non-intrusive, practical approach to early post-trauma support, emphasizing safety, connection, calm, self-efficacy, and hope. Rather than encouraging detailed discussion of traumatic events, which may be harmful for some individuals in the immediate aftermath, psychological first aid focuses on addressing immediate needs, providing practical assistance, and fostering supportive connections. For those who develop acute stress disorder, brief trauma-focused cognitive behavioral therapy shows strong empirical support. These interventions typically include psychoeducation about trauma reactions, anxiety management techniques, gradual exposure to trauma memories and reminders, and cognitive restructuring to address unhelpful beliefs that maintain symptoms. Several randomized controlled trials have demonstrated that 4 to 5 sessions of trauma-focused cognitive behavioral therapy can significantly reduce acute stress disorder symptoms and have the risk of developing subsequent PTSD. Pharmacological approaches to acute stress disorder have shown mixed results. While medications are not typically recommended as first-line treatments, they may play an adjunctive role for specific symptoms or when psychological interventions are unavailable or insufficient. The most extensively studied medications include selective serotonin reuptake inhibitors, SSRIs, which have established efficacy for PTSD but less evidence specifically for acute stress disorder. Benzodiazepines, despite their temporary anxiety-reducing effects, are generally not recommended due to potential interference with natural recovery processes and risk of dependence. Emerging research explores novel approaches targeting the neurobiological mechanisms of trauma responses, such as beta blockers to disrupt fear memory consolidation or hydrocortisone to normalize HPA axis functioning, though these remain experimental rather than standard clinical practice. Special considerations arise when addressing acute stress disorder in certain populations. Children and adolescents may express distress differently than adults, often through behavioral changes, somatic complaints, or regression in developmental milestones. Older adults may face compounded challenges when trauma interacts with age-related stressors such as health problems, cognitive changes, or social losses. First responders and military personnel face unique challenges due to repeated trauma exposure and cultural contexts that may stigmatize psychological distress. Cultural factors profoundly influence every aspect of the trauma response, from the meaning assigned to the event to help-seeking behaviors and preferred healing practices. Effective intervention requires adapting evidence-based approaches to address these population-specific needs and contexts. The concept of resilience provides an important complement to traditional pathology-focused approaches to trauma. While much research and clinical attention focuses on those who develop significant distress following trauma, the majority of trauma-exposed individuals demonstrate remarkable resilience, maintaining relatively stable, healthy functioning despite adversity. Understanding the factors that promote resilience, including flexible coping styles, strong social connections, meaning-making abilities, and certain biological factors, may inform prevention and intervention efforts. Rather than viewing resilience as an immutable personality trait that some possess and others lack, contemporary approaches consider resilience as involving dynamic processes that can be fostered and strengthened across development and following adversity. The COVID-19 pandemic has created unprecedented challenges related to trauma and stress disorders. Healthcare workers facing overwhelming demands, individuals experiencing life-threatening illness, those losing loved ones under traumatic circumstances, and communities facing economic devastation have all encountered potentially traumatic stressors. The pandemic has also disrupted many traditional sources of social support while simultaneously creating barriers to mental health care. These challenges have accelerated the development and implementation of telehealth approaches to trauma assessment and treatment, which show promising results while improving access for traditionally underserved populations.